Hello, future nurses. Today we're going to be talking about our ECG dysrhythmias. So as always, I like to kind of start with a refresher. So this refresher is for our cardiac conduction system. This is a very good video. It's about 3 to 5 minutes long. And what it shows is like the SA shooting off. So our natural pacemaker of the heart kind of shooting off, and then how that relates to both the contractions and release of our heart muscles, as well as what that looks like on an ECG. So it's kind of a good video to watch. You can locate it in Momentum. So I wanted to just go through an overview. So cardiac electrical activity can be monitored by using an electrocardiogram, so an ECG. We've got 3 different types that I want to talk about today, and you can see those all on the next slide. The first one is a standard 12-lead ECG, which is usually called a resting ECG. So on here, I'll flip it to this one here, you can see this 12-lead here. And it's connected to a machine. Then you've got your ambulatory ECG or your Holter monitoring. That's this gentleman here. And those ones are typically sent with patients when they go home. If your cardiologist decides that he wants to watch your rhythms, he'll give you that Holter monitor. Then you've got your continuous cardiac monitoring or your telemetry. So in the hospital, this lets our patients walk a little bit more, and you can see it here. So all the information from it is sent to a station or a tech that will watch it. Some of these techs are located on the floor themselves. Some of them are located on a different floor. These can be used to diagnose things like dysrhythmias, chamber enlargements, myocardial ischemia, injury, or infarction. It can monitor the effects of electrolyte imbalances or medication administration. So when we start getting into our dysrhythmias, we'll go into different types of medications that may cause these dysrhythmias, as well as some of those electrolyte imbalances. Cardiac dysrhythmias are a heartbeat disturbance. So it can either be beat formation, beat conductions, or myocardial response to that beat. These electrocardiogram graphs use electrocardiography uses electrocardiographs to record the electrical activity of the heart over time. So what it is we're just trying to see the electrical activity of what's going on with the heart. Because if we're not beating appropriately, then we're not causing the contractions we need. The electrocardiogram is connected by wires, leads. So you can either call these, most of the time what you'll hear them called is leads, that are placed on the skin electrodes, which place on the chest and limbs of the patient. So we've got, these are our electrodes and these are our leads here. Continuous cardiac monitoring requires the patient to be in close proximity to the monitoring system. So whether it's like a Holter device where they carry it right there with them, or a tele where they've got it, there has to be some sort of connection to the machine. Now with your 12 leads, the machine is right there with them. So they'll bring the 12 leads to the patient's room. Now, like when I say, what's it called? When I say this, I repeated myself several times with this, so I really want you guys to get this in your head. ECG monitoring will not detect shortness of breath, chest pain, or other manifestations of acute coronary syndrome. So you need to be looking at your patients. So allowing your patients to know that they need to report new or worsening manifestations. So always make sure that you're checking your patient. So if you see something on here like ST elevation, we all know that that could indicate a myocardial infarction. First thing you want to do, check your patient. Look at that level of consciousness. See what's going on with them. So why is my patient on this? It can be things like dysrhythmias. So things like they've got sinus bradycardia, tachycardia, AV blocks, AFib, ventricular asystole, PACs, PVCs, supraventricular tachycardia, ventricular fibrillation. So it can be that the patient already has these dysrhythmias, or it can be presentation. So it can be things like a history of cardiovascular disease, a myocardial infarction, hypoxia, which will look like shortness of breath, indigestion, fatigue, acid-base imbalances, electrolyte disturbances, kidney failure, liver or lung disease, pericarditis, drug or alcohol use, hypovolemia, or shock. Now, with this, as the nurse, you need to think about the presentations that you will see in the patient. Because the patient, if they don't know what a heart attack is, they're not going to go in there and say, I'm having a myocardial infarction. So you need to hear what they're saying. So if they say things like they've got shortness of breath, indigestion, or that they're just feeling fatigue even after having a good night's rest, those are all cues that, hey, maybe I need to ask my doctor for an electrocardiogram. So pre-procedural, you want to prepare the patient for a 12-lead ECG, position the patient in a supine position with chest exposed, wash the patient's skin to remove any oils, clip, do not shave any hair that may interfere with the electrodes, and attach one electrode to each of the patient's extremities by applying the electrodes to a flat surface. I like this picture here because it kind of gives you a good visual of where you're going to place these leads. Now, V1 through V6 will show you like the circumference basically of the heart. It goes like all the way around so you can see what's happening with it. So looking, hold on, it's back. Okay. So you do want to be careful with where you're placing these leads. So inter-procedure, you want to monitor for manifestations of dysrhythmias, so things like chest pain, decreased level of consciousness, shortness of breath, and hypoxia. Tell the patient to remain still and breathe normally while the 12-lead ECG is being performed. Post-procedure, you remove the leads, print the ECG report, and notify the provider. And you want to continue to monitor the patient for any dysrhythmias, because this 12-lead is basically just a quick picture. So it's like a snapshot of what's happening to your patient. So if all of a sudden 30 minutes goes by and your patient complains about chest pain, you do want to go back in and check them. Or you may have to order for a follow-up, like you may have to request an order for a follow-up ECG. So this video here, it's on momentum as well. It's the electrocardiogram ECG basics. It's a very helpful video. It's about 8 minutes, I believe, and it shows like lead placements along with what that rhythm is going to look like in the heart. This here I wanted to show you because it kind of gives you a quick kind of view of what the video talked about, and we'll watch that video in class. But for example, with these 12 leads, it'll show you like V1 is associated with where that lead's located. So it kind of gives the physician or the cardiologist the ability to know, hey, I know that there's damage in V1. So they can associate that with a certain part of the heart. So dysrhythmias can be classified in 2 ways: site of origin and the effect on the rate and rhythm of the heart. Your site of origin are things like your sino-arterial SA node, arterial area, arterioventricular AV node, or your ventricle. So it's like the origin of where this dysrhythmia began. Effect on the rate and rhythm are things like your bradycardia, tachycardia, heart block, premature beat, flutter, fibrillation, or asystole. These can either be benign or life-threatening. Life-threatening relates to decreased cardiac output. So if there's any sort of thing that's causing decreased cardiac output or ineffective tissue perfusion, that's when we move towards it being life-threatening. Sometimes with our older adults, we will see that increased activity can cause dysrhythmias. And this little picture here, I just think is helpful in kind of grasping this idea that there is a difference between a cardioversion and defib. So a cardioversion is an elective procedure and it's synchronized. So usually it's that 50 to 200 jolts, consent form, and EKG monitoring. Defibrillation, it's the emergency. It's I'm doing CPR, I've got VFib or VTAC, I'm trying everything I can. This picture is also helpful where you've got your cardioversion versus your defib. Like I said, cardioversion, the shock is synchronized. With your defib, it's asynchronized, so it's done with just that automatic AED. You've got a lower amount of joules in your cardioversion opposed to your defib. CPR is not done in cardioversion. Defib resumes CPR after shock. Cardioversion is with your stable patients. Defib is with your unstable patients. Cardioversion, an example that we use that for would be something like AFib. With the patient who's going to have AFib, you just want to make sure that they don't have any clots and that we do have them on an anticoagulant before they go in, which we'll talk about that when we continue. Defib is usually with VT or VF. This little memory trick is kind of helpful for cardioversions. Cardioversions are carefully planned. So CC. Defib, if it has a V, ventricular tachycardia, or ventricular fibrillation, give them the D, defibrillation. Treatment options, like I said, cardioversions versus defib. Cardioversions have that pulse. It's an elective. Defib, pulseless. I'm working on it. Okay, our dysrhythmias. So we've got different types of dysrhythmias. You've got your sinus node dysrhythmias, which these originate in the SA node. So the SA node is our natural pacemaker. So these are things like our sinus brady, our sinus tachycardia, and our sinus arrhythmias. And when you look at these sinus rhythms, a lot of times they're going to still have their P wave, QRS, and they're going to look very similar to our normal sinus rhythm because they have appropriate rates. The difference is how fast or how slow, or if all of a sudden there's like an extra beat there. Then you've got your arterial dysrhythmias, which originate from the focal in the atria, so not the SA node. So these do not originate in the SA node. They originate in the arteria. And these are things like our AFib, our A-flutter, or our premature atrial complexes. So all of these dysrhythmias that have arterial in the name are usually your arterial dysrhythmias. Then you've got your junctional dysrhythmias, which originate with the AV nodal tissues. So these are things like premature junctional complexes, junctional rhythms, non-proximal junctional tachycardia. So your junctional dysrhythmias will usually have junctional within the name. Then we've got our ventricular dysrhythmias, which originate from the focal within the ventricles. So these are premature ventricular complexes, our VT, our VFib, our idioventricular rhythms, and our ventricular asystole. So all your ventricular dysrhythmias are going to have that ventricle or that ventricular within the name. And then we've got conduction abnormalities, which is our first, second, and third degree heart blocks. Okay. The first one we're going to talk about is our sinus bradycardia. So with our sinus bradycardia, our ventricular and arterial rates are usually less than 60 in adults. The ventricular and arterial rhythms are regular. QR shape and duration is usually normal. P wave is normal and consistent in shape, always in front of the QRS complex. PR interval is consistent between 0.12 and 0.20 seconds. And the PQRS ratio is 1:1. So looking at this, like I said, it looks very similar to normal sinus rhythm. The difference is it's a much slower rhythm. So some of the potential causes can be things like athletic training. So a lot of our aerobic exercises can cause the muscles still a heart. So a lot of times in those people who are very, very athletic, they can cause their heart to their muscle to grow. So they're actually getting more push with every heartbeat. So every heartbeat, they're getting a lot more blood flowing through, so they require less heartbeats. It can be vagal stimulation, which vagal stimulation can be things like the patient's vomiting, we're suctioning the patient, or severe pain. Medications such as calcium channel blockers are beta blockers, so those can slow our heart rate down. Increased intracranial pressures, myocardial infarctions and hypoxemia, and acute decompensated heart failure. So nurse will monitor for the hemodynamic changes, and you want to determine if the rate is becoming inadequate for perfusion. So it's one thing if the patient still has adequate perfusion. So if they're like 59 beats per minute, but they're still perfusing okay, opposed to somebody who's systematic 30 beats per minute and they're losing that level of consciousness. So as the nurse, you just want to determine, is this rate becoming inadequate for perfusion? Am I nervous that this is going to impede on my patient's ability to function appropriately? So our symptomatic bradycardia. So sinus bradycardia can cause that decreased cardiac output that will likely cause activity intolerance. It does not typically cause pain with it if it's just a normal sinus bradycardia. However, when we start getting that symptomatic bradycardia, that's when we can start developing chest pain, hypotension, syncope, dizziness, confusion, ST segment changes, PVCs. So like I said, you want to assess the patient and determine the hemodynamic effects. So always check your level of consciousness. Because like I said, if all of a sudden the patient's heartbeat is 35 beats per minute, you want to go assess your patient and see how's their level of consciousness. With it, your treatment choices can be pharmaceutical, which is atropine, or a pacemaker. Atropine 0.5 milligrams is usually given through rapid IV bolus, and it can be given every 3 to 5 minutes with a maximum dose of 3 milligrams. You can also get a pacemaker, which we'll talk about later. The next one we've got here is our sinus tachycardia. So these are our ventricular rate and arterial rate is greater than 100. Ventricular rate and rhythm is regular, so we're not seeing any abnormals there. QRS shape and duration is usually normal, maybe regularly abnormal. P wave is normal and consistent in shape, always in front of the QRS, but it may be buried in preceding T wave. So if the rhythm's going fast enough, there may be a P wave that's kind of buried within the end of that T wave. PR interval is consistent interval between that 0.12 and 20, and then your QRS ratio is 1:1. Your sinus node creates an impulse faster than normal, because remember, these sinus ones come from the sinus node. So some of the clinical associations can be psychological or physiological stress. So if your patient is very, very stressed, it can cause them to have this increased heart rate. So sometimes what you want to do is try to get your patients to calm down a little bit and look for that underlying issue, which we'll talk in the next slide. So if they're breathing very, very hard and they're not getting air, sometimes you can request for the patient to be put on oxygen. Hypermetabolic states, hypotension, hypovolemia, anemia, hypoxia, MI, heart failure, sympathetic response, medications. So things like if we give atropine inappropriately, think about it. Atropine was to fix bradycardia, but if I give too much atropine, I'm going to send my person to what? Tachycardia. So just being aware of what these medications can do. Stimulants like illicit drugs, caffeine, nicotine. So these are our sinus tachycardia. So medical management is usually determined by the severity of the problem to treat the underlying cause. So for example, analgesics for pain, fluids for hypovolemia, possible vagal maneuvers, beta blockers to reduce heart rate and myocardial oxygen consumption, calcium channel blockers. So your clinical symptoms for this are things like hypotension, dizziness, dyspnea, and angina, because the heart's just going so fast. So if your heart's going so fast, the diastolic filling time decreases, cardiac output decreases. So we're not having enough time to actually fill these areas up, so we're not getting enough output. Treatment, you can do things like vagal maneuvers. But make sure you're being careful with that, and that you're letting someone know if you're trying that. So asking them to kind of bear down, forceful sustained coughing, putting ice water on the face, fixing some of those underlying issues. So if they're short of breath, thinking about oxygen to fix that. Some of the medications. So if none of these like alternative things work, then we can move towards our medications. We've got things like adenosine, beta blockers, amiodarone, and analgesics. Because if they're in severe pain, then we want to give them something for that pain. Now, adenosine, what I want to worry about that with you is a lot of times it's reserved for your superior ventricular tachycardia, so your SVT, and it will cause short period of asystole. So adenosine is one of those drugs that if you see an order for it, make sure that there's a provider in the room because it will have that very short period of asystole. Now, if none of these medications can work, then we can do, and if you've got persistent SVT, then we can do synchronized cardioversion. So we can synchronize that on the Zoll and actually shock it back into rhythm. So this is one of those ones that we can use a cardioversion for. Next one we're getting into is our premature arterial contractions. So your ventricular and arterial rate depends on the underlying rhythm. So this one really depends on what's causing it. Ventricular and arterial rhythm, irregular due to early P waves, creating a PP interval that is shorter than others. QRS shape and duration. The QRS that follows the early P wave is usually normal, but it may be abnormal and it may be absent. Your P wave is early and different P wave may be seen or may be hidden in the T wave. Your PR interval, the early P wave has a shorter than normal PR interval, but is still between that 0.12 and 0.20. And your QRS ratio is usually 1:1. So with this, your clinical associations can be things like caffeine, alcohol, nicotine, stress, fatigue, hypermetabolic states, hypokalemia, and heart disease. So significance, healthy heart, none. So if you've got like a healthy heart, you don't really have to worry about this. It's just that kind of heart skipped a beat. If you've got heart disease, it may herald onset of arterial fibrillation. So if you've got like a history of heart disease, that's where we get a little bit more concerned with a PAC. So PACs, if you've drank a lot of coffee and you had that skip beat, it may not necessarily require us to do anything for it. But if you've got heart disease, then you may want to watch out for possible AFib. Speaking of AFib, here we come. So AFib, which is one of our tachydysrhythmias. So ventricular and arterial rate is 300 to 600. Ventricular rate is usually 120 to 200 if it's untreated AFib. Ventricular arterial rhythm, highly irregular. So when you see this, this is the one that kind of looks like it's just skipping a beat. QRS shape and duration, usually normal, but it may be abnormal. P wave, no descriptable P waves. PR intervals cannot be measured. Sorry, no discernible P waves. So you can't actually see these P waves. They're just kind of all over the place here. QRS ratio, many to 1. So AFib causes the electrophysiological changes in the arterial myocardial. So it's that remodeling of the electrical arterial circuit and structural remodeling, which promotes the basis of continuance of dysrhythmias. So basically what's happening here is we've got like our normal heart here where SA node shoots off and it's supposed to go to your B node here, and then it makes everything kind of go where it needs to. With AFib, it's basically like that quivering of the heart. So it's just constantly, it's not beating regularly. And one of the things you want to look for is that these do not have any clear P wave. So that's one of the main things, is there's no clear P wave with AFib. So AFib depends on how fast the heart is going, is the kind of issues the patient may have. You can have stable AFib with good perfusion, or you can have things like AFib RVR, which cause poor perfusion. So that's what you really want to look for, is how fast this rate is going and am I getting good perfusion? So with any of these dysrhythmias, it all comes back to what is my perfusion like? So some of the risk factors are things like advanced age, hypertension, heart failure, diabetes, obesity, obstructive sleep apnea, cardiac ischemia, alcohol consumption. And you've got increased risk if somebody has had heart failure, myocardial ischemia, or a stroke. Significance is that reduced ventricular filling. So there's no arterial kick, and you can lose about 25% of your cardiac output. And that's what we're really looking for, is that reduced cardiac output. Decreased perfusion only if AFib is significant. So symptoms, ECG waveform shows no clear P waves. So when you're looking at that and you see that there's no clear P waves, palpitations, symptoms of heart failure, so shortness of breath, hypotension, dyspnea, and pulmonary edema. Okay, so here are some of the things that we need to look into for these patients. Okay, so treatment depends on the cause, duration, ventricular response rate, patient's age, and comorbidities. Your treatment for arterial fibrillation is to terminate the rhythm or to control the ventricular rate. There's a priority because it directly affects cardiac output. A rapid ventricular response reduces the time for ventricular filling, resulting in a smaller stroke volume. So for your patients with AFib lasting longer than 48 hours, anticoagulant therapy is recommended before other attempts to restore sinus rhythm. So before we jump into some of these medications, we try doing our anticoagulant therapy. Electrocardioversions indicated for a patient who are hemodynamically unstable. So if the patient is unstable, that's when we get into these elective cardioversions. If a patient is in AFib more than 48 hours, anticoagulant therapy is needed for 3 weeks before cardioversion and 4 weeks after successful cardioversion. So you just want to make sure that are they on some sort of warfarin before they have this elective cardioversion. A TEE is used to confirm absence of thrombi in order to perform a cardioversion. So administer heparin immediately prior to the cardioversion. So with this, why do we care so much to make sure that we've got our patient on an anticoagulant as well as we have a TEE before we do that cardioversion? Thinking back about AFib. So AFib is that rhythm that's kind of moving everywhere. It's like not working together. And if we think about that, then there's an issue that the patient may develop a blood clot. So they may develop a blood clot. So we want to make sure that we don't allow any coagulation, so we don't shock it and then cause that blood clot to basically move somewhere else. So that's why with AFib, if the patient has that new onset of AFib and they're not on any home medications or hospital medications, the first thing that the physician is going to try is something like warfarin. That's the very first thing they're going to try. And then after that, if that doesn't work, they may try something like amiodarone, beta blocker, something of that nature. And then if that doesn't work, then we do a cardioversion. And before we do a cardioversion, we're going to do that TEE. So when you're studying this and you're trying to look through for AFib, what you want to do is kind of make a list of what you need to get done first. So the very first thing, somebody comes in, they've got no medications. First thing the doctor is going to prescribe is something like warfarin. They're going to prescribe some sort of anticoagulant. And that's just because we don't want any of that blood, because it's all wanting to clot with one another, to clot. From there, if that doesn't work, we're going to try pharmaceuticals. So our pharmaceuticals are things like our amiodarons, our beta blockers. If that doesn't work, then we're going to have a TEE to confirm the absence of thrombi in order to perform a cardioversion. And then after that, if we don't see any thrombi, then we have the cardioversion. So just in a nutshell, remembering that it starts with warfarin first, get that anticoagulant therapy first, then try meds to convert or prevent, so things like amiodaron. And then after amiodaron, we're going to get a TEE to confirm the absence of a thrombi. And then from a TEE, we'll have that cardioversion. And with this, you want to use caution when giving medications to patients with an AV node. Conduction. You want to be careful, like not giving patients beta blockers to patients who have bronchospasms, depending on the type of beta blocker you have, because it can block the action of epinephrine and binding to the receptors, causing that shortness of breath. Oops. So one of the other things we can do is a catheter ablation, which destroys specific cells that are the cause or central conduction route of tachydysrhythmias. So what happens here is a catheter is threaded to the site of origin, delivers sound waves, causing localized cell destruction, destroys pathway for AFib. You also have a cryoablation, which catheter induces extremely cold temperatures to destroy selected cells. And for that, we just want to monitor, cardiac monitor for any recurring dysrhythmias, then recovering from sedation and signs and symptoms of a stroke. So a lot of these cardiac procedures, you always want to watch for those signs and symptoms of a possible stroke. So our A flutter, your ventricular rate and your arterial rate. Arterial rate ranges between 250 and 400. Ventricular rate ranges between 75 and 150 beats per minute. Ventricular and arterial rhythm. Arterial rhythm is regular. Ventricular rhythm is usually regular. QRS shape and duration is usually normal, but may be abnormal. Your P wave is going to have that sawtooth shape. So whenever you see this sawtooth shape, we're thinking of A flutter. Your QR interval is difficult to determine, and QRS intervals go 2 to 1, 3 to 1, 4 to 1. And what happens here is there's a conduction deficit in the atrium, which causes rapid impulses. So our treatment, we want to slow the AV nodule conductions. So possible vagal maneuvers, possible adenosine. And if you remember, with adenosine, you want to make sure that you want to wash them because they will have a brief asystole. So observe patient for flushing, dizziness, chest pain, but it does have a short half-life, so 10 seconds. So you administer it rapidly. They can be on beta blockers, calcium channel blockers, electrical cardioversion, catheter ablation. So cardioversion, we're using that shock. Ablation, we're either like burning off the pathways or freezing off the pathways. You want to treat with anti-thrombolytic therapy. So like I said, it's the same thing as AFib. We start with that antithrombic therapy. Then from there, we try medications. If that doesn't work, I can get a TEE to make sure that there's no blood clots. Then I can try my cardioversion. So this is how to give adenosine, 6 milligrams IV, rapid IV push, followed by 20 mLs normal saline, elevate arm to promote rapid circulation of the medication. So this is your hyperkalemia. You'll see peaked T waves. So if you've got a patient who has way too much potassium, one way you can look at it is through the heart. It is considered a medical emergency. Your priority medication is IV calcium gluconate. It stables the myocardium. Regular IV insulin is given because it temporarily draws potassium inside the cells, and you give D5W or D50 to prevent hypoglycemia, and you can potentially also give sodium polystyrene, which essentially we're trying to get them to poop out all of that potassium. Now we've got our lovely junctional dysrhythmias. So with these, your ventricular arterial rate, ventricular rate is 40 to 60 beats per minute. The arterial rate is also 40 to 60. Ventricular rhythm is regular. QRS shape and duration is usually normal. P wave may be absent after the QRS complex, may be inverted. SA node fails to fire, or the signal is blocked from increased vagal tone, or the impulse is not conducted through the AV node. The impulse from the AV node usually moves in a retrograde fashion that produces an abnormal P wave occurring just before the QRX complex. However, P wave may be absent or follow QRS. The impulse usually moves normally through the ventricles. So with these junctional dysrhythmias, they originate within that AV nodule tissue. SA node not conducted. So basically skipping the pacemaker of the heart. QRS is usually normal. Treatment is usually same as bradycardia. If symptomatic, atropine, emergency pacing. Junctional rhythm, AV node becomes pacemaker of the heart. P wave may be absent. Follow the QRS may be introverted, and your rate is usually 40 to 60 beats per minute. So on this, you see how like the P wave is just kind of disappearing on this rhythm here. Premature junctional complex, note the premature beat with absent P wave. So there's like just a premature beat, but you don't actually see the P wave here. Premature ventricular contractions, ventricular dysrhythmia originates from the focal within the ventricles. Premature ventricular complex, PVC, ventricular tachycardia, VT, ventricular fibrillation, VFib. And so all of it's kind of originating from this ventricular side here. So the first one is our PVCs. The rate depends on the underlying rhythm. Rhythm is irregular. QRS is greater than 0.12, so it's wide and bizarre. P wave is visibility depends on the timing of the PVC. So depending on where it hits is when you'll see the P wave. PR interval usually not measured. Unifocal PVCs usually originate from the same ventricular focus. Multiple focal PVCs are several irritable ventricular focal that discharge. Each focus will produce its own uniquely shaped PVC. So basically, in a nutshell, what your PVC is once again that skip beat, except this time it's coming from the ventricular space. Some of your causes can be cardiac ischemia or infarction, hypoxia, acidosis, electrical imbalances, digitals toxicity, and it may also occur in a healthy patient. So caffeine, nicotine, alcohol can all cause this to happen in a healthy patient. So your risk factors are anything that increase workload of a failing heart, and usually caused by electrical irritability in the ventricular conduction system. And when PVCs occur in patients with underlying heart disease, it may indicate that impending lethal ventricular arrhythmias. So you just want to make sure that you're watching these PVCs, especially in your patients who have that history of heart issues. They're usually not serious, but you do want to keep an eye on them. Evidence that a higher frequency of PVCs precedes development of cardiomyopathy with increased incidence of heart failure, increased mortality. Occasional PVCs, no treatment, monitor, frequent, possible amiodarone, sotalol. And then here you can just kind of see where the PVCs are popping through. For ventricular bigeminy, every other beat is a PVC. Ventricular trigeminy, every third beat is a PVC. Ventricular quadgeminy, every fourth beat is a PVC. So ventricular tachycardia, this is 3 or more PVCs in a row. So while one PVC may not be anything to worry about, once we start hitting 3 or more, we're getting concerned. Rate is greater than 100 beats per minute. Causes as in PVCs, MI, low ejection fraction, greater risk of lethal ventricular tachycardia, long QT syndrome, electrolyte imbalances. Okay. So this is one of our uh-oh rhythms. If you ever see this, it is something you want to take in consideration. Always make sure that you are checking on your patient. If all of a sudden it starts alerting you and you see this is one of those deadly rhythms. It may be life-threatening, severe decrease in cardiac output, hypotension, pulmonary edema, cardiopulmonary arrest. So make sure that you take this seriously. You want to identify the rhythm. Is it monomorphic or is it polymorphic? So monomorphic, they all look the same. Polymorphic is where we're starting to get where it looks kind of different. Determine existence of a long QT interval. Comorbidities. And then, like I said, there's different forms of ventricular that exist depending on the QRS shape. So monomorphic VT QRS complexes are the same in shape and directions. They all look very similar. So it's basically this one here. They all look the exact same. Then you've got polymorphic QRS complexes gradually change back and forth from one shape, size, and directions to another over a series of beats. But this is where you get your torsades de points. Torsades de points is that polymorphic VT, which is preceded by a long QT interval. Some of the causes can be things like low potassium, calcium, or magnesium levels. Rhythm is likely to go down. Patient will become pulseless. Immediate treatment required. So treatment depends on the stability of the patient. It may be antiarrhythmic medications, cardioversion if we've got a pulse, defib if there's no pulse. So making sure that if I see this torsades de points, I am very concerned about it. So stable VT with a pulse, continue 12 lead ECG, amiodarone, sotalol. Symptomatic synchronized cardioversion for monopistic VT. Pulseless VT, code blue, begin CPR, immediate defib. So as soon as you call for assistance and you get that defibrillator, you want to make sure you initiate CPR. So make sure that you're doing that as soon as you lose that pulse. Your ventricular fibrillation causes can be things like coronary artery disease, resting MI, cardiomyopathy, acid-base balances, electrical shock. So the issue with this is you've got no arterial activity. So basically everything is down here. It's abnormally fast and chaotic heart rate. Ventriculars quiver rather than beat. So we just have this quivering here. No cardiac output, absence of a heartbeat, no palpable pulse, no respirations. So if we've got no pulse, what is the first thing we're going to do? Call a code, start CPR, and start firing up that defib. So absence of heartbeat, palpable pulse, and respirations, cardiac arrest, and death immediate. So these ones, like I said, there's some rhythms that are your deadly rhythms. And these are the ones that you want to know as the nurse immediately upon going out of nursing school or going on the floor. If I see this rhythm, that's my own rhythm. I'm immediately going to that patient's room and checking on the patient. And if the patient doesn't have a pulse, then I'm calling that code blue. I want to begin CPR, immediately defib. ACLS, epinephrine, 1 milligram IV push every 3 to 5 minutes. Follow with 20 mLs IV flush, elevate extremity, amiodarone. And remember, we elevate that extremity to make everything go faster. Amiodarone, 300 milligrams IV push, second dose in 3 to 5 minutes, 150 milligrams IV push. Asystole and absent QRS complex. No heart rate, pulse, respiration. Confirm in 2 different leads. So you can see it in 2 different spaces that it's not there. Clinical association, advanced cardiac disease, severe conduction disturbances. So you want to rapidly assess to identify the cause. So H and T's, things like hypovolemia, hypoxia, hydrogen ions, hyperkalemia, hypothermia. Your T's are your toxins, tamponade, tension pneumothorax, thrombus, thrombosis. And you want to treat this the same as pulseless electrical activity, so that high quality CPR. Without any treatment, it is fatal. Your conduction abnormalities, so block in a conduction through your arterioventricular node. So first degree AV block, second degree AV block type 1, second degree AV block type 2, and third degree AV block. Causes can be things like medication, so digoxin, fatal anergic blockers, calcium channel blockers, MI, cardiomyopathy, increased vagal tone, and assess PR intervals and QRS response. So conduction block first degree, arterial impulses are conducted through the AV node slower than normal. So PR interval assessed for the AV block. Your PR interval is greater than 20 seconds. So this interval here is going to be greater. So your first degree AV block looks very similar to your normal sinus rhythm. So what you need to do is make sure that you're watching to see, is this greater than your 0.20 seconds? Usually no clinical significance, and they're usually asymptomatic with this one. So your second degree arterial ventricular blocks. You've got type 1, and that type 1 is your Winkelbach. PR interval becomes longer with each succeeding ECG complex until there is a P wave not followed by a QRS. Repeats a pattern. So on here, what you'll see is, sorry, Mosbitz or Winkelbach type 1. It's becoming longer and longer and longer until it drops off. Your type 2 or your Mosbitz 2, PR interval remains consistent, QRS suddenly drops. QRS ratio changes 2:1, blocks 3:1, 4:1. So it's also the second degree AV block type 2 is also known as your Mosbitz. It's almost always a disease of the distal conduction. Yeah, sorry. I lost my train of thought. I'm sorry. But yeah, so when you're looking at these, you just kind of want to see, is my P wave not followed by a QRS, and is there a repeat in this pattern? While this one, my QRS is just going to suddenly fall off the face of the earth. In your third degree AV block, your P wave is unrelated to the QRS. So if you look at this, you've got random P waves here. None of them are actually connected with this QRS. So no arterial impulse passed through the AV node. Ventricles generate their own rate. So on here, that's what you're really looking for, is do I have a bunch of P's without them following your QRS? So because your blocks can be kind of difficult when you're looking at them, you want to see your QRS and the relationship between them. So for example, with this Winkelbach or second degree type 1, what you're looking for is that you've got a P wave, but it's not followed by a QRS. So you see how there's these random P waves, but no QRS. It slowly gets longer and longer and longer till our QRS is just gone here. And this basically repeats in pattern. With our type 2, the PR interval remains consistent. So with this one, your PR is basically the same. So if I put this together and I copied this, all my PRs are going to be the same. It's my QRS that suddenly disappears. So type 1, the issue is my P wave is not followed by a QRS. So there's a P wave and then there's a P wave, but no QRS. This one, my PR intervals are the exact same. It's just like the QRS disappeared from it. And this one, the P wave does whatever it wants. It's not consistent at all with my QRS. First degree, these are our treatments. First degree AV block, usually not clinically significant. Second degree AV block type 1, usually not clinically significant. Second degree AV block type 2, you pace. Third degree AV block, immediately pace. 3 medications for bradycardia ACLS algorithm are things like atropine, dopamine infusion, epinephrine. And you can use that transcutaneous pacing. So your third degree AV block is significant because it reduces cardiac output, hypotension, syncope, ischemia, heart failure, shock. Treatment, immediate transcutaneous pacing, and then followed by a permanent pacemaker. And this is life-threatening because if the atria and ventricles are not beating together, the heart cannot maintain perfusion. So one thing that we've said consistently is it's all about perfusion. So that's why this one's one of those dangerous ones. If medications alone are ineffective in eliminating or decreasing a dysrhythmia, certain adjacent medical therapies are available. The most common therapies are electrocardioversion and defib for acute tachydysrhythmias, implantable devices, internal cardio defibrillations for chronic tachydysrhythmias. So we're going back to our cardioversions and defibrillations. So this is treatment for our tachydysrhythmias. Major difference is in the time of electrical current. So this is a Zoll here, and you can use the Zoll to both do cardioversion as well as defib. So cardioversion, delivery of the current is synchronized with the patient's electrical events. So defib in sync mode. So we can use this for things like AFib, or do this with things like A-flutter or our SVT. Defib, delivery of the current is immediate and unsynchronized. Ensure defib is not in sync mode. So this one is not trying to sync up to it. So your biphasic defibrillator delivers electrical shocks from one paddle and then automatically redirects its charge back to the originating paddle. So that's kind of how it works here. So these are your pad positions. Some of your complications can be things like skin burns. Other risks include injury to the heart muscles, abnormal heart rhythms, and blood clots. So risk for injury is if you have a blood clot and you let this electrical impulse go through, then it can cause them to move that clot somewhere else. You should never use defib on a patient who has a pulse or who is in an alert, because this can cause a lethal heart rhythm if you accidentally set them into the wrong heart rhythm. So when you're using these pads or paddles, you want to use appropriate conductive medium, maintain good contact between the paddles and skin, ensure no one is touching the patient when shock is delivered. So when they say clear, you want to make sure no one is touching the patient or the bed. Clear, no one is touching the patient or the bed. Sorry, you are not touching the patient or the bed. And clear, final visual. Electrocardioversion, electrical impulses are synchronized to discharge on the QRS. Avoid discharge during repolarization, which may result in VT, VF. Paddles are anterior or posterior. If cardioversion is elective and dysrhythmia is lasting more than 48 hours, you may administer anticoagulant for a few weeks before the procedure. Patients should be NPO before the procedure, moderate sedation, and bag mask respirations. Defib, VT, and VF. So this is the unsynchronized shocks. So initial shocks, biphasic is going to be 120 to 150 to 200 joules. So that's like basically I can either use the padded ones, or they also have Let me just show you the picture here. You can either use the pads or the paddles, and they'll go on either side, and the whole purpose is they'll be sending that shock. Transcutaneous pacing. This one is for sympathetic bradycardia with a pulse, unresponsive to atropine. So if atropine does not work, then I can use this transcutaneous pacing. Most defibrillators have pacing pads. So a lot of times you'll use like similar pads to the ones that you had set the shock through. Impulse travels through the skin, can cause significant discomfort. You only really use this in emergencies, and sometimes sedation or analgesics may be administered. So what happens is the electrodes are connected to the defibrillator, which serves as a temporary pacemaker generator. Second degree may need transcutaneous pacer. Third degree block, patient needs temporary pacing until permanent pacemaker is placed. So you can have, these are going into our more implanted. So this here, this transcutaneous pacing is for emergency situations. This one is, now we're going into, okay, our patient, this is for long-term use. So an automatic implanted cardioverted defibrillator, or AICD, is a small electronic device. It's implanted into the chest to monitor and correct abnormal heart rhythm or arrhythmias. It detects and directly treats potential lethal rhythms. On here, we've got our pacemaker, which provides electrical stimulus to the heart muscle. Indications may be things for symptomatic bradycardia, AV blocks, second and third, tachydysrhythmias, two components, electronic pulse generator, electrodes, and it can be temporary or permanent. So the temporary ones you'll usually have after a CABG. They'll go ahead and have these external pacemaker wires so they can control the heartbeat, or if they need to send a different pacemaker while the patient's trying to get that new blood flow. Your AICD versus pacemaker. So an implanted cardioverter defibrillator, or ICD, so you'll see it as ICD or ACD, is a specialized implanted electrical device designed to directly treat cardiac tachyarrhythmias. So it will directly treat it. A permanent pacemaker is an implanted device that provides electrical stimuli, thereby causing a cardiac contraction when intrinsic myocardial electrical activity is inappropriately slowed or absent. So the AID is fixing those tachycardiac. It's basically, an AICD is usually for your tachyarrhythmias. So things like my heart's going too fast, so I'm kind of slow it down with a little bit of a shock. Or your pacemaker is my heart is too slow, so I'm going to do something to ump it up. So pacemakers, you've got external pacemaker, which is your transcutaneous pacing. So those are the ones in the emergency settings. Your temporary epicardial pacemaker, generated on the outside of the body, leads in the epicardium, used in heart surgery. So those are the ones I was talking about after open heart surgery. You've got temporary endocardial, generated on outside of the body, lead wires into the endocardium, used for temporary heart abnormality or when waiting for a permanent pacemaker. And then you've got your permanent pacemaker, which is generated implant in subcutaneous pocket, and lead wires are placed into the endocardium. And as the nurse, you want to monitor pacemakers for malfunctions and battery failure. So just looking for those things. And it can be single or dual chambered. So pacemakers on the actual EKG. So pacemaker spike appears on the ECG when pacing is initiated. Capture means the appropriate ECG complex follows the pacing spike. So P wave should follow an arterial pacing spike. So if it's an arterial pacing spike, then you should see the P wave following this capture. Because impulse starts in a different place than the patient's normal rhythm, the QRS or P wave will look different. Pacemakers are generally set to sense and respond to intrinsic activity. An asynchronized pacemaker is set to pace but not sense. Pace is at a constant rate independent of patient's intrinsic rhythm. So when you're looking at this, you'll see those are your pacer spikes here. So basically what happens is that electrical charge is going in order to make sure that the heart is beating. Synchronized bioventricular pacing, so cardio resynchronized therapy. Pacing leads in the right atrium, right ventricle, and left cardiac vein. Left ventricular dysfunction and heart failure are both reasons we might use this. So here are some of our complications for our pacemakers. So dislodgement of pacemaker electrodes, so it can minimize patient activity, restrict activity on the side of implantation, immediate post-op, refrain from lifting the affected arm higher than the shoulder. Monitor ECG to detect pacemaker dysfunction, educate patient to carry a medical identifying alert. So you want to educate the patient. So avoid strong electromagnetic fields. So things like MRI, television transmitter towers, no objects with magnets near. Don't put cell phone in shirt pocket. Avoid welding or use of chainsaw. Monitor or generate may trigger anti-theft devices and airport security arms. So handheld devices used to screen airports may interfere with the pacemaker. So you just want to make sure that the patient, when you're talking to them, that they always, if they have an MRI scheduled, that they notify the provider before they go to the MRI, or that you're notifying the provider before they go to the MRI, because it can interfere with the pacemaker. Also things like cell phones can interfere with it, looking for magnets, and then washing that chainsaw. Safety use, most household electronics are safe to use. Microwave oven, electrical tools. Be sure to turn off gas-powered engines before working on them, though. Like I said, a microwave should be fine, your electronic tools should be fine. It just comes back with those things that have magnets in them. Nursing interventions after permanent device inserted, monitor patient's heart rate and rhythm. Pacemaker malfunctions detected by examining pacemaker spikes. So that's how you can see if it's malfunctioning. So you know how before I said, watch to see if it's malfunctioning. If the pacer spikes aren't where they should be, then you kind of want to let the provider know. Patient's cardiac output and hemodynamic stability, assess to identify response and seeing if that pacing is helping. Abnormalities should be reported. Monitor the site for bleeding, hematoma, infections. Monitor for signs of pneumothorax, so that shortness of breath, asymmetrical chest movement. Patient is assessed for anxiety, depression, or anger, so ineffective coping. And then the final thing I've got here is just like a pacemaker memory tricks. So hopefully this will kind of help you remember, what's it called? Things you need to know about pacemaker. That's also on momentum. As always, thank you, and I will see you in class.